I would first like to introduce our first presenter, and this is Dr. Sameen Jafari. She's our neurologist here at Wentworth-Douglass Hospital, and she comes to us from Massachusetts General Hospital, where she completed her fellowship. She's board certified in neurology, neurocritical care, and neurophysiology. And she is our stroke program medical director, and she has a wonderful talk presented to us tonight. So go ahead, Sameen. Thank you.
Thank you for that kind introduction, Kathy. So I am Sameen Jafari. I am the stroke director at Wentworth-Douglass Hospital. So this is a topic very close to my heart. Thank you to everyone for joining us today. This is our annual event for stroke education and awareness that we do for the month of May, which is the National Stroke Awareness Month. So we're going to talk about taking stroke head on and how we diagnose and manage this at Wentworth-Douglass Hospital. Oh, there. Okay. So, we take stroke very seriously at Wentworth-Douglass. We are the first primary stroke center certified by the Joint Commission in the state of New Hampshire. This was back 10 years ago. And what this means is that we provide evidence-based, up-to-date stroke management per national guidelines from the American Heart and Stroke Association. We're also a Mass General Hospital telestroke site, which means that we have access, and so do our patients, to MGH stroke neurologists 24/7, including all of the management and treatment options they have available as well. We treat stroke as soon as somebody walks through our emergency room, throughout the hospitalization, and then we try and follow you through once you leave our hospital into any rehab facilities, any therapy you might need, so we can provide comprehensive care all the way through your illness. So, unfortunately, many people, either personally or to someone they know, has been touched by stroke. It is unfortunately very common, and it's a common cause of mortality. So some of these stats are very frightening. If you think about, every 4 minutes somebody dies from a stroke in the United States, it accounts for 1 in 20 deaths. And 795,000 people will experience either a new or a second stroke. And affects women, men, and not only mortality, but stroke is a very serious cause of long-term disability. It is a life-changing event for many people. And so who can be affected by stroke? These are just some famous faces. So you could be an athlete, for the New England Patriots. You could be a child with no medical history. Stroke does not discriminate. It can happen to anyone. You can do everything right, you can do everything wrong, and unfortunately, it can affect you at any time. So what is a stroke? What do we mean when we talk about stroke? So stroke really is when you have brain damage, usually because of lack of oxygen and nutrients, when you block a blood vessel, and that part of the brain dies, which is irreversible. The two main types of stroke, when we call something a stroke, is ischemic and hemorrhagic. Ischemic stroke is the most common. So 80% of stroke that we see in a hospital is ischemic. And that's basically, like that picture shows, you have a blockage or a clot that blocks a blood vessel, stops blood flow, and the brain around it dies. It can either be embolic, which means that the blood clot shot up from somewhere else in the body, or thrombotic, which is a slow accumulation of plaque and clot in the blood vessel until it finally blocks it. Hemorrhagic stroke, which is less common, only about 15% of stroke we see is of the hemorrhagic type, can be much more sudden and scary when it happens. So that's actually when you have a blood vessel that either because of longstanding high blood pressure or something you were born with, an aneurysm or dilatation, suddenly rips. Blood is allowed to fill the brain and basically pushes on the brain and causes damage that way. And then you have what we call TIA, or transient ischemic attack, colloquially known as a mini stroke. And this, for me, is no different to a stroke. It's caused by the same thing, with the only benefit being that the brain was able to rally itself and recover so that the symptoms actually disappear, usually within 24 hours. But this makes it actually much more important for us to be aware of and diagnose, because it tells us that this person had a lucky break, right? They don't have any disability, but they're at risk for it to happen again. And this time the brain might not respond. So what can we do for stroke? It's sudden, it can strike at any time to anyone, so we really need to be vigilant and look out for it. At Wentworth-Douglass, we use this mnemonic, which is called BEFAST. It's an updated version of the old mnemonic that a lot of people know and actually tell me when I see in the hospital, which is FAST. The B and the E were added to include other types of strokes that might not be so obvious. So, if somebody is off balance, that's your B. If you have change in vision, you lose vision, you have floaters, that's eyes. And then is weakness of your face, weakness of your arms, trouble talking, stuttering your words, your speech. And then the T is the most important part, which is time. If you recognize any of these symptoms in yourself or anyone you know, then you need to call 911, and you can't spend time, waste any time. And so that's why also the mnemonic stands for Be Fast, call 911. And the reason, a lot of people will tell me, I didn't want to, our EMS providers are already so stretched, I don't want to waste their time. Stroke is an emergency, and it doesn't matter if it's just a little bit of slurring of your words or change in vision. It's an emergency, and that's what EMS is there for. Not only can they get you to where you need to go right away, they can actually start treatment at that time. They can start to protect the brain and make sure that things are getting better. And this is one thing that I try to tell people is that stroke can only really be managed in the hospital. This is not something you call your doctor for. This is not something you wait for your primary care appointment in 2 days. You need to get to the hospital to get treated right away. So, sometimes people say there's no treatment. Why should I come? Can stroke be treated? Yes, definitely. But time is so important. And this picture shows it, I think, very clearly. If you see, in the corner where it says 10 minutes, that little red area, which maybe I can point, here. So this blood vessel is blocked and the brain around it is already dead. It lost its blood, it can't survive. But the rest of this green area is vulnerable. It also gets blood from that blood vessel, but it's trying to take it from other places. After an hour, you see that without any rescue, the area that's dead is getting larger and larger. And by 6 hours, that part of the brain is gone. And this turns a TIA or a stroke where you can recover into a stroke that causes irreversible disability and maybe even death. And so time is everything. The sooner we identify the symptoms, the sooner we see you, the sooner we can help you, the sooner we get you home and back to your normal life. And this is why we do have 2 therapies that are the only ones that we can either stop or even reverse the symptoms of a stroke. And one of these is called IV thrombolysis or TPA, and the second is surgery or intravascular intervention. And I clarify that because it's not open brain surgery. It's surgery where we put a little wire in through the blood vessels to fish out a clot. The first therapy, the clot busting drug, we can only use in certain situations because it's a very potent treatment. We can do it at Wentworth-Douglass Hospital. It's only successful or safe to use within 4.5 hours of the last time someone was completely normal. And so this is the reason I want everyone to get to the hospital as soon as possible, because if you're a candidate for TPA, I want you to be able to get it. The second surgery is for people who either don't respond to TPA or it's a smaller subgroup of people that would be eligible for it. We don't do this at Wentworth-Douglass Hospital, but we're very closely associated with Mass General that does. And part of that relationship means is that if you come into our hospital with a stroke, no matter what time, what day, we have 24/7 coverage that our physicians and providers in the emergency room can reach out to them. We have one of those machines where you have a little TV screen, so you'll be able to see the neurologist. They're able to see you, they're able to guide the management, use their expertise, use the tools that they have available in Boston to help us manage you here. And if for some reason you need more care than we can provide at Wentworth-Douglass, you do get priority for transfer, especially for patients that need surgery or they have, an aneurysm that's ruptured. No matter how full or busy Boston is, they have a policy that they will take you. They will find room to treat you as soon as possible because they also understand that time is urgent and immediate. And although Boston seems far, we've sent people there that once they got to the door to when they were in the OR suites about to have a procedure, so the needle was touching their skin, it was 10 minutes. Because Mass General does this, they have everything set up, they're ready to go. And part of our relationship is that we start the test, the blood pressure here. So already half of your management's been done before you go there. I just want to make a little note of, not all strokes are strokes. So luckily, or fortunately, sometimes, what we think might be a stroke might be something else that's more treatable. So it could be just low blood sugar or a migraine or something called the Bell's palsy, which are not disabling or, threatening conditions. And again, it's important to evaluate those because it might keep happening if we don't treat it appropriately. Of course, there's other serious causes that can present like a stroke. So seizures, infections, some medications and substances can cause it. And of course, the worst thing would be a brain tumor. But that's what we're designed to do. We're designed to evaluate and make sure we identify those as well. And so what happens, so like I said, we're a primary stroke center. We have an entire stroke team that's job it is to see these patients, evaluate them, and then treat them. So it starts from our EMS providers that we have a good relationship with, our nurses, nursing assistants, then different types of physicians or providers in the hospital from all different specialties, our radiologists, our sleep, our imaging and lab techs, all the way through to our therapists, our case management and discharge planning groups that will help you all the way through the hospitalization and then to discharge. And so what really constitutes hospital management of stroke? The real purpose is to diagnose, so actually get you a diagnosis and start managing the stroke, which really happens from the moment you step foot in the emergency room. And that's also where we evaluate to see, do you need more care than we can provide at Wentworth-Douglass? Do you need Mass General or surgery? And then we can start the treatment and get you to where you need to go. We do the testing to get answers, and then we start treatment for your blood pressure, for your blood sugar, diet, medications, and then evaluate you for therapy, plan a safe discharge to get you home ultimately, which is our goal, and then educate you, your family, with a plan of what to do now going forward and how to keep in touch with the providers that you need to. This one is more important for me, but also for our patients. Is the second goal of a hospitalization is really to figure out an answer. Why did you have your stroke? Because we really want to make sure it never happens again. And the reason for that is to figure out what happened and to correct it. And for that, again, sometimes we don't get answers while you're in the hospital. That's something that might happen once you leave and you see your primary care doctor or your neurologist. This is one tool that we use in the hospital, and it's part of how we individualize care for all our stroke patients, right? Not one stroke is the same, not one patient is the same. Our nurses are very good at pulling out this stroke card because it's easy to tell someone, stop smoking, fix your blood pressure. But this really tailors down to you. And it might say, well, are you low risk? Are you in the yellow area? Are you high risk? Is your issue the fact that you're a smoker, but your blood pressure is perfect? Or is your issue that maybe you need to do more exercise? We really try to have a judgment-free zone to help you to identify things that we could fix at this juncture to make you recover and make sure the stroke never happens again. And so there's a lot of things that we can change if we just know about it. And this applies to even young patients, so the sooner we learn about these, the better. And so this includes blood pressure, cholesterol, diabetes, heart arrhythmias like atrial fibrillation, exercise, tolerance and level, and then of course, smoking. And there's a lot of things that you can't change. And it's unfortunate, especially, age, gender, ethnicity plays a strong part in picking people who might be at risk for stroke, including family history. So if you have family where grandparents or parents who've had a stroke, unfortunately, that increases your risk. And the sooner we know and address those risk factors, the safer you'll be. So, what does stroke care really mean afterwards? So again, once we diagnose your stroke, start your treatment, it's an ongoing kind of relationship with healthcare to make sure that the things that we can fix, we do. And some of them, come later on. So that's why you need to keep in touch with your primary care doctor. We usually plug people in with neurology, sometimes cardiology is involved. And, we want to give you ownership that you need to know why you're taking the medications you are, what the reason is, why we're doing what we're doing. And our hope is that once someone's gone through a stroke and, the life-changing event that it is, they're able to educate their family and friends, tell them what to look for and to even maybe help one other person go through the process would make a difference. But we know it's hard, like I said, it's definitely life-changing. So we're there to support you through it, helping you during good times and bad and setting goals that might, are achievable for the time that you're at. And so for me, stroke recovery, again, is something I'm very passionate about. This is why, although I'm mostly a hospital doctor, I do see my stroke patients in clinic. And I love to see them in clinic because they always look better than in the hospital. And, they're in their clothes, they're with their family members. but it takes time. I always tell people a chest infection takes a week or two. How can we expect the brain to get better so quickly? So recovery really is weeks to months. And the number that I quote is really 3 months to maximal recovery. And that's what we want and hope for. But you have to use it so you don't lose it. You really have to train your brain, because that part of the brain that had the stroke is irreversibly damaged. It's unfortunately dead. But the brain is a marvelous thing, and it can find other ways to go around that area. And that's where our therapists come into play. We have physical therapists that will focus on getting people walking, using stairs, getting their strength back. Our occupational therapists are there to help you go back to doing the things you need to do, getting dressed, going to the bathroom. If you, need things to do for work, handwriting, doing tools, using machinery. And then our speech therapists, they have a wide range of things that they look at, including the simple, like just swallowing, being able to have food, to speech, being able to talk well, being able to communicate, and then also memory and cognitive long-term effects from stroke. And that's where kind of I use this to say that I always tell people we never give up. We always have hope, right? Strokes are always worse when they happen. They continue to get better, and it takes time. Although we like to think that in 3 months you'll be back to normal, I've seen people that show improvement years down the line. And everything that the people who recover have in common is that they don't give up. They keep trying, they keep forcing their brain to do the things they need to do to get back to normal life. And that's this concept of neuroplasticity, which is, although the brain is one part of the body that we can't replace or transplant, it can heal itself. It has other parts of the brain that will take over. And it might never be back to normal, but at least you'll be able to do the things you want to do. And that's very important for us. And that's really what we tailor our approach to. And sometimes it can be as simple as doing repetitive actions. So like memory games, rehab exercises, other things. Sometimes we just give someone a squishy ball and we ask you just to squish it 50 times a day. But that's all that's necessary to remind the brain that it needs to keep going over this pathway. It needs to keep getting better. And we like to see slow improvements. So if one day you can't move your thumb, but the next day you can, we'll take it. Every improvement that we see is worth it. And then this is just a comment to say that, I've mentioned it several times, but strokes really are life-changing. A lot of people tell me, I did everything right. I ate healthy. I don't smoke. I go to the gym. Unfortunately, I've had people who have strokes at the gym. Like, what else could I have done? And it's very humbling to realize that, unfortunately, nothing. And I tell people, as a neurologist, I see people in the hospital that have a stroke in front of my eyes, and we couldn't predict it or change it or treat it. It's one of those terrible things that we try, especially, in Boston, they're trying their best to be able to predict it beforehand. But, it causes a lot of depression, which is very understandable. And that can really affect the way people engage with therapy, with healthcare. It can be something that makes you just want to give up. And so this is another thing that is part of our overall look. We screen for it, we look for it, and we validate it, that this is a normal part of healing after something so life-changing. And it doesn't just affect patients, everyone's life changes. So close family, friends, everyone has to suddenly reevaluate something that they never thought possible. And so that's part of healing and moving on from it. And so in that vein, unfortunately, because we see and do this, we see patterns. And so we're there to support you, in every way. We do have a stroke support group, which because of the pandemic is virtual, which might make it easier. Those are the details, but the most up-to-date details will be on the website. So you can always Google it and to see it. And then Lindsay is available by phone or email to get in touch with for this. And so kind of like as a summary is, what do I do if I see symptoms of a stroke and it's in yourself or other people? Remember, it's an emergency. You can never be faulted for calling 911. They know how to respond to it. They know how to take it seriously. If you have the slightest suspicion, call 911, get to the hospital, get to the people that can identify, figure out what's going on, and get you to the right treatment at the right time. Because our brain is important and it is, irreplaceable. So we want to do whatever we can to get it better as soon as possible. So we welcome any questions. I know there was a lot of talking and a lot of information. So if you can use the Q&A function, we'll collect all of them and then we'll discuss them right at the end. Thank you.
Thank you so much, Dr. Jafari. That was a wonderful talk. I so appreciate it. And again, just to reiterate, if you do have questions, place them in the Q&A area. We'll monitor that, and as soon as we get towards the end of our program, we'll look at those questions for you. But we have much more to come. I'm very excited to introduce Rita Mary O'Donnell. She is our speech therapist supervisor here at Wentworth-Douglass Hospital. She has her master's in speech language pathology, and she is closely affiliated with our stroke support group, and she treats patients in the outpatient setting. And she has a very close relationship with our stroke survivor and his wife. And we've asked them to come and share their story to really kind of bring it home what happens to people when they do have a stroke. So I would let Rita introduce them to you. And Rita, you're on mute.
Knew that was going to happen. So round two. Hi, everyone. Rita O'Donnell, speech pathology supervisor at Wentworth-Douglass Hospital. And I also have the pleasure of co-leading the stroke support group that, as Dr. Jafari says, meets monthly, now virtually, the third Thursday of every month. And through that stroke support group, I had the pleasure of meeting Rob and Becky Clerkin. And so I will go ahead and let them introduce themselves in regards to telling their story. And it's just been a pleasure to be a witness to their journey and see their progress. So Rob and Becky, take it away and unmute.
Thanks, Rita. You good?
Yeah.
Okay. Hi, my name is Rob Clerkin. This is my lovely wife, Becky. I've had 2 hemorrhagic strokes. First one happened in 2013. I was just under 50 years old. The second one happened in June of last year. I'm currently 58. And both times Becky got me immediately to the hospital, Wentworth-Douglass, and they diagnosed me, called a helicopter, and took me down to Mass General. And thanks to Becky, I'm still alive to talk to you today, and very grateful for that. Thank you.
You're welcome. My pleasure.
So go ahead.
So there were just some things that I wanted to share from my perspective as Rob's caregiver. And I just would reiterate what has been shared in terms of time and not sleeping. The very first stroke, it was our first experience. I got home, Rob had sent me a text asking when I'd be home. I was on my way home. I got home, he came out and met me in the driveway and said, I'm not sure what's going on, but I can't see my hand. Or no, he said, something's going on with my hand.
Yeah.
And so, and I thought, okay, maybe he's having a heart attack. And so I was asking him all kinds of questions. And finally I said, well, what's going on with your hand? And he held his hand up and he said, well, I can't see it. It was his left hand. I can't see it. And I thought, okay, well, I don't know what this is, but this is strange. So I said, get in the car, let's go to the hospital. And he said, well, I think I'm going to go take a nap and I'll see how I feel afterwards. And I said, I just don't, this doesn't feel right. Get in the car, we're going. And we literally are right up the street from the hospital. It would have taken longer if we had called 911. So we just got in the car. We got there and, they got him in, as they looked at his blood pressure, it was sky high. He had never had high blood pressure before this. And they did the CAT scan. The doctor met me in the hallway as they were wheeling Rob back in, and he put his hand on my shoulder and he said, how are you doing? And I thought, okay, this is strange. He said, I'm fine. How's Rob doing? And he said, let's go talk. And he said, he has had a cerebral hemorrhage. And one thing that I would say is that I think language is funny. That was scary. But as we went through the process and people then started talking about it being a stroke, that felt so uncomfortable for some reason. Like it was a scary word. We've had lots of time to get used to it now. But so they immediately sent the helicopter, brought him down. We went through that experience. What I would say as a caregiver is, first of all, it is so helpful to have notebooks. I did not have a notebook initially. And as I sat in the hospital, I think it was day 2, I thought I need a break. There's a CVS right up from Mass General. And I went and got a notebook because I just had all kinds of questions that, when the doctors were coming through, this was pre-COVID, so you're able to be there longer. I needed to write down my questions. I needed to keep track of what I was noticing for symptoms for Rob. And I think that that's true as a caregiver throughout the sort of critical crisis stage, but then also the recovery, that, you know, you as a caregiver are an important piece of the care team because you know this person. And so when there are shifts in their personality or in how they're reacting, those might be too subtle for the hospital to necessarily pick up on, but you can say, you know, this isn't how he normally talks, or, you know, that this, that these reactions aren't how he would normally react. And then in terms of recovery, we would often go for follow-up appointments and they would say, Rob, how are you feeling? And what would you say?
Fine.
Yeah, I'm great. And then I would pull out my notebook and say, okay, here are the things that I've been noticing. And so being able to just kind of keeping track of, well, what are the challenges that are presenting? What are the things that I'm seeing that he might not necessarily be paying attention to or aware of? So a notebook has been an invaluable thing. Other practical things, knowing your loved one's allergies, knowing what kinds of medications they're on, those were really helpful. Knowing passwords, being able to get into his phone. Both times that he had the strokes, I didn't know his boss's name, and luckily it didn't impact his ability to communicate. He was able to talk, so I could say, what's your boss's name? I need to call and say, I don't think you're coming into work tomorrow. So being able to get into a phone and, you know key people, depending on the roles that people play, the person that has the stroke, you know, the partner or caregiver, because I also went through similar situations with my brother and I was his caregiver, knowing, you know, who's their mortgage company, how do you get into different accounts? Those things are really important. Having that information somewhere accessible to people that are potentially going to be helping you, having paperwork drawn up, having power of attorney, having healthcare proxy. You know, once this happened, I had to get in touch with his work. We had to start the FMLA, the leave process. I had to get in touch. Luckily, Rob's work had short and long-term disability, but I had to start all of that. And they won't talk to you if you don't have this paperwork to send to say, I'm able to act on his behalf. Nobody wants to think about this stuff, but boy, it's such a relief if you have it in place. And again, the other thing nobody wants to talk about is end of life, but to know what somebody's thoughts are about things. If that happens, it is such a comfort to know that I'm following what your wishes are. I was in the position, the second stroke, I needed to make the decision. Yeah, absolutely.
Yeah, the second stroke was much worse. By my layman's calculations, it was 3 times worse than the first one. They actually had to remove part of my skull on the right side to relieve the pressure on my brain. And for the first one, I was in and out of the hospital in a week. For the second one, probably what, 3 months?
Yeah.
So it's been quite a road. Basically lost all of last summer and all of last fall, just by being in Mass General, which is where I should have been,
Right.
and Spalding Rehab for a couple of months as well. So, and every person that treated me or helped me knew what they were doing, and they were very nice. I can't say enough good things about both those places and Wentworth-Douglass. But she has been on the opposite side of what I've been through. I would rather it be this way than have her hurt, because there's no way that I could do what she did for me. And quite honestly, I don't know who people or how people who don't have a support system like Becky get through this, because even with just the insurance things that you need to do, if you have to do them by yourself, you're moving up a river, and it's tough.
Yeah. I mean, obviously, I'm happy to have helped. I think just to kind of go off of a couple other things that you were talking about, you know, the care that Rob has gotten has been phenomenal. But again, I think as a caregiver, to know that you're going to need to be an advocate.
Yeah.
The very first stroke, he was put in the neuro ICU at Mass General. And then like a day and a half later, they said, well, we're going to discharge you because we don't have any rooms on the regular floor. You're not at this level of care anymore. But he was at a 10 out of 10 in pain. And I just said to the doctor, no, I'm not taking him home at a 10 out of 10 in pain. I cannot manage this. And the fact that you don't have a bed for him, that's a problem that you guys have to sort out. I'm not taking him home. And he said, well, I'll let him stay overnight. We'll send him home tomorrow. And I said, well, we'll have this conversation tomorrow. And then it was the same conversation. He was still at a 10 out of 10 in pain. And I said, I'm not taking him home. We're not managing him at home with this. And so finally by Friday, his pain level came down. It was manageable and he came home and you know, we began the outpatient rehab. This stroke, there were just, again, several different things that came up that I needed to advocate for him. There was a particular nurse that just, her communication style didn't work with Rob and it just made him more agitated. And so I just said, you know, I can see that she's doing a great job, but it's just not a good connection here and it's not good for Rob and I want her removed from the care team. And we got a different nurse and it was all fine. And I made it very clear, you know, this is not about her. It's just, this is not the right fit for them. And I felt a little uncomfortable about that, but then I thought, I'm his advocate. He was just in no place to be able to talk for himself. And there just were lots of different things that came up like that. When he went to have his cranioplasty, when they fixed his skull, I was logging into his patient portal and checking all of his blood work. And I was very concerned about some of the levels and I kept asking about it. And I was told, you know, oh, well, it was from blood loss from the surgery. And I kept asking because the numbers, they were checking it regularly and the numbers kept declining. He had a surgery, the surgery on Monday was supposed to come home Wednesday. Tuesday, he was doing great. It really looked like he'd be coming home Wednesday. Wednesday morning, I logged into the patient portal early. They had done more blood work. Again, the numbers declined. I called and I just pushed and I said, I'm really concerned about this. And so they said, okay, well, we'll do a transfusion, which means he has to stay one more night. Well, early morning hours of Thursday, he ended up with a hematoma and they had to rush him in for another surgery. And if I hadn't listened to my intuition and really pushed on it, he would have been home and it would not have been an ideal situation. So I think really listening to your intuition, paying attention to it, and, you know, just kind of knowing that you are part of the care team. One of the other things, there were a couple other things when he was in the ICU and was intubated and sedated, I said, I want to play music. And so our family got together, we did a playlist for him on Spotify and we got a wireless speaker and we just had it playing continually in the room. And music is important to Rob. I wanted some tether for him to stay grounded, a little emotional. But it made such a difference in terms of all of the people coming into the room. I mean, whether it was somebody coming in to empty the trash or to change his bedding or, you know, take his blood or the nursing staff, people commented about like, wow, this is such a great feeling in this room. And I think it really made Rob look as a patient to them rather than just a body in this bed that they're checking vitals. And I don't want to minimize how they look at it, but it just really humanized him. And then the other thing is I brought in flannel blankets from home. He was always freezing. Vermont flannel blankets are fabulous for hospital beds. And I brought several and it just, that kind of thing made a world of difference for him.
It really did.
Yeah. And I guess a piece of advice that I would give is if it was important to me to communicate to people. I logged into Rob's Facebook because he has got a whole community of people that he grew up with, that he was in high school with, that he was in the Navy with, that he's worked with over the years, that I don't have connections with. And especially the second stroke, it was so serious that I didn't know if he would survive it. And I didn't want the first notice to be, we're sorry to announce that Rob has passed. And I wanted people to know what was going on. And for my belief, I felt that the more people that had good wishes or prayers or positive energy or right, that it helped. It was important to have boundaries around that because then you get a lot of people that will offer all kinds of advice. or say, hey, I Googled and have the doctors looked at this. So just kind of knowing what you don't necessarily want to let in and just thanking people, but not getting sucked into that was helpful. It's really helpful if you are touched by this and it's not you directly, to make a blanket statement of, if there's anything I can do to help, let me know, is not helpful. When you're in crisis, it's hard to even think about what you need, let alone, well, what do I have permission to ask for? So people that gave me concrete things, you know, hey, let me know if you need the lawn mowed. I can pick up groceries. Can I bring stuff down to you at the hospital? People that gave concrete suggestions, that was so helpful. And gift cards. People gave us gift cards for gas or for coffee. And at first it made me so uncomfortable because I thought, we don't need this. It gets expensive quickly, number one. And number two, it was just sort of a concrete connection to people that truly cared about us and that wished Rob's recovery. And it was a wonderful thing and a helpful thing. Yeah, we had people that offered to pay for, I stayed in a hotel for a month and a half and I didn't pay for a single night because people just called the hotel directly. And so I think that there are ways that, you know, if you really want to help somebody, think about a concrete way. It just, you know, and again, the people that said, how can I help? I so appreciated it. I knew what they were doing, but it's, your mind is reeling. You can't think of what it is you possibly need in that moment. So, and I think sort of one of the last things is just, again, kind of advocating for your loved one. The whole idea of recovering from a stroke and the depression, that's real. And, you know, just how important it is to communicate with each other, to communicate with the caregivers of if you're experiencing those kinds of things. And then for me, what was really important is just to really think holistically and think about, okay, what are other things that we need? And so once Rob came home and I knew he was ready for outpatient care, I did research. I mean, to me, it was just like when I was trying to pick, you know, daycares for my kids when they were born or schools. And I had a whole list of things that I was looking for. And the fact that Wentworth-Douglass is right here in our backyard and just the holistic approach that they have, that it was PT, speech, occupational therapy, and then the support group and driving assessment that was part of it. Yeah, the caravan has been, you know, that gives Rob a modicum of independence that he doesn't have to rely on me to get him there all the time. Yeah, there just were so many things about the program that have been invaluable, and you know, we're grateful that we happen to live here and that we have access to that
Very
as a
much so.
resource. Yeah. And I could go on and on, but I think those were the big things that I just wanted to highlight.
Well, thank you so much. When I was preparing for this, I made sure I had my cup of water and a pen and pencil. I didn't know I was going to need a Kleenex because you did really bring me to tears with, it was so heartfelt and remarkable. And when someone is going through something this serious, to have that support. So really, I was really touched by your story. So thank you so much.
Thank you.
And we're going to come back with a few questions for sure. But this kind of is a great segue from hearing from Becky and Rob. I'd like to introduce Sherry Wells. Sherry is also a stroke survivor from a couple of years ago. She did present here at Wentworth-Douglass Hospital and also went to Mass General as well. And over a couple of years, she really has developed a passion for helping people who have gone through a similar type of experience. So much so, even with COVID, she was trying to find ways to reach out to stroke survivors. And so she came across this opportunity with the American Stroke Association, and it's called Survivor to Survivor. And I'm going to let Sherry talk about this. And it's a program that we hope that we can implement here at Wentworth-Douglass Hospital soon.
Thank you so much, Kathy, for that nice introduction. Becky and Rob, my heart goes out to you. I was right there with you, but your story is so inspiring. I put together a little PowerPoint presentation to just kind of speak to the Stroke Survivor to Survivor program. So as Kathy said, I've been looking for ways to be able to reach out and volunteer as much as possible. So the American Heart Association actually has the Stroke Survivor to Survivor program. And you're probably saying, what is this? So it's a telephone peer support program created by a group of stroke survivors in conjunction with the American Stroke Association and collaboration with WDH staff. It's run by stroke survivors or stroke caregivers, volunteers with special training, and it's overseen by hospital on-site coordinator, which will be Kathy Danforth. Sorry. So what are the benefits of the Stroke Survivor to Survivor program? It encourages stroke survivors to manage their own care while offering support and guidance, educates stroke survivors on the need for treatment compliance to reduce risk of stroke recurrence, provides valuable resources such as stroke support group listings, news, and related activities and events. What are the goals of this program? It's to provide encouragement, support, and guidance, to connect other stroke survivors with support programs and activities, to offer the most updated resources in stroke education, to monitor the survivor's progress and seek referral guidance, and provide stroke survivors to survivor volunteers the opportunity to give back post-stroke. How the program works is patient and/or family are introduced to the program by hospital staff at discharge. Once the patient agrees, a short enrollment form is completed. Survivors and/or caregivers will receive phone calls twice a month for the first 2 months after discharge. Calls consist of following up and asking if there are any questions, concerns, or additional information needed. And patient has the opportunity to withdraw from the program at any time. That's pretty much the program in a nutshell. And I'm truly passionate about this program and about all the efforts that Dr. Jafari and Kathy and Rita have put in to support this. Thank you for letting me present.
Thank you for presenting that, Sherry. And we've got a group working together very diligently to really have this program come to light. So we're looking forward to hopefully this fall to do that. So thank you.